various morphology on urinalysis. Now, based on all the tables that we've seen, ultimately, you also want to be able to identify your various crystals, cells, and casts. And the next section here, that's exactly what we're doing. I'm not going to get into explanations because I've done that plenty on the tables above. Let's begin. So we have a test known as your phase contrast microscopy, and that'd be the best to then identify what's known as dysmorphic RBCs. And what does a dysmorphic RBC mean to you? It's an RBC in which it gets disfigured as it passes through the glomerulus. Protrusion from the RBC membrane, result of damage from glomerular inflammation. There's a difference between dysmorphic RBC versus just finding RBCs. They're signs of hematuria or of glomerular origin. So this is dysmorphic RBC. Let's move into sediment with neutrophils. Well, the arrow here is then pointing to a bilobe neutrophil. And if you're thinking neutrophil, would you tell me as to what test is going to be positive here? Is it esterase or nitrites? Good. Esterase. Neutrophils. Specific for kidney? No. It could be urethritis, cystitis, or it could be pyelonephritis. So it'd be more specific for the kidney. A WBC cast, which is not what this is. Do you understand what I'm showing you? In the previous discussion, when I showed you the dysmorphic RBC, none of those were casts. Now we have oval fat body. Once again, I'm not showing you a cast. An oval fat body polarization, quote unquote, Maltese cross. You tell me quickly. What is your differential in terms of classification? Nephritic or nephrotic? Good. Nephrotic. Excellent. So as you lose more protein, your lipid accumulates due to cholesterol. Nephrotic syndrome. What about hyaline? Do you remember this? Do you see these critters in your urine? You could barely see them. So make sure you're seeing something in the urine. Those transparent, translucent casts. It's the first time I'm showing you a cast. Literally aggregates. So it looks like blocks going through the urine. Now, as dangerous as it may seem, actually it's not. So therefore, acellular and could be just part of a patient who's been working out and you expect to find hyaline casts. What are these? Aggregates of protein. Then we talk about another cast. Now, do you see the difference between casts and cells? So casts will look exactly like that, aggregates of cells or proteins. Now, a cellular cast here is an RBC cast. Now, you tell me, where is there damage taking place? Good. Kidney. Nephritic or nephrotic? Nephritic. Excellent. Remember H? There it is again. Hematuria, hypertension, RBC casts. At least know that. Let me add in one more. Might as well. Do you lose protein in nephritic? What was my question? Do you lose protein in nephritic? Yeah, you do. Is it as significant as nephrotic? No. Are we clear? So nephritic will be less than 3.5 grams of protein. Nephrotic will be greater than 3.5 grams of protein. Every single time that we go through discussion, I'm going to keep adding information in there based on the foundation that you already have. This is an RBC cast. This is WBC cast. Stop there. What's your first question? Okay, so I found the WBC cast. So what kind of cells are these, or aggregates of? Two things. It could be either neutrophil or eosinophil. If it's a neutrophil, give me diagnosis. Is it urethritis? Is it cystitis? Or pyelonephritis? If it's a neutrophil and it's a WBC cast, it has to be. Good. Pyelonephritis. Tell me about your patient. Oh, pain back here, huh? By the hips, flanks, what it's called. Fever? Of course. Of course. Okay, continue. What other type of cell might it be? It might be eosinophils. If it's eosinophil, then you're thinking, good, interstitial damage, drug-induced perhaps, tubular interstitial nephritis. This one is a cast, but these are dead cells. And these dead cells, well, the patient here, they'll give you history. They have to. The history here is the following. The patient has congestive heart failure and has right-sided failure and positive JVD, pitting edema, so on and so forth. And you end up doing a BUN, or you take a look at the labs, and you take a look at your BUN creatinine ratio, and you find that to be elevated. And let's say that a little while longer, and by a little bit while longer, weeks maybe, and you find that your BUN creatinine ratio is decreased. Put all this together. What did I give you? I gave you a congestive heart failure. What happened to cardiac output? Decreased. especially, well, in addition, I gave you positive JVD and I also gave you pitting edema. What side? Right-sided heart failure. Good. Decreased cardiac output. I said initially the labs were an increase in BU and creatinine ratio. So all we have at this point is a pre-renal azotemia, don't we? I told you weeks had gone by. Now at this point, the patient presents with a decreased BU and creatinine ratio. What's my diagnosis? Especially find these casts. Good. This is renal azotemia, acute tubular necrosis. What caused the necrosis of these tubular cells? Ischemia. So if you have decreased cardiac output, could you have ischemia to the kidney? Of course. You have decreased cardiac output. Do you see the significance? The casts are numerous. And you have ATN. They're dead cells. These casts are a sign of acute tubular necrosis. And if they get, let's say, a little bit of mixed in with maybe blood and protein, it might be called muddy brown granular casts, is what you've heard of. Take a look at this. There's a difference between this cast, which may seem a little translucent and could potentially confuse you with hyaline cast. But if your patient was exercising and you see something not like this, but a little bit thinner, that'd be a hyaline cast. If your patient has diabetic nephropathy, and you find these big fat casts in the urine, not so good, huh? And so you might be thinking about chronic renal failure or fractal degeneration of renal tubular cells. Further damage. Huge, waxy, broad. You could probably get on this thing and ride down the river. It is huge, waxy, and broad. On urinalysis, if it's WBC, infection, inflammation, neutrophils, but it's not telling you where exactly, except for the fact it's a urinary tract. Hematuria, RBCs, once again, if you find just RBCs, you have no idea if it's a kidney origin or if it's maybe the bladder origin, right? But you do know somewhere in the urinary tract. What type of RBC is more specific for the glomerulus? Good. A dysmorphic RBC.